Good morning, and welcome to the International Kidney Cancer Symposium, Day 2, Session 5, Multimodality Therapy for Metastatic Renal Cell Cancer. My name is Jason Abel. I'm at the University of Wisconsin. I'd like to introduce my fellow moderator, Dr. Randa McKay.
Hello, everyone. So before we get going, given that this is the 30th anniversary of the KCA, we're going to start with a trivia question. What is the correct order of, you guys should see that before you hear. What is the correct order ascending by year of these, that these therapies were introduced? All righty, give you guys some time to complete those questions. All righty, we'll go ahead and get the results going. Awesome, look at that. So 71%, oh, still shifting around, Nexavar, Sutent, and Lida. Alrighty, so we're gonna get going with our first presentation to the Pieter de Mulder Award Lecture. Dr. Axel Becks from the Netherlands Cancer Institute in Amsterdam will be presenting on the perioperative treatment of advanced renal cell carcinoma. Dr. Becks, and actually before we do your talk, we have one more question before you get going. So we've got a 63, let's send this over to you guys. All right, a 63-year-old male presents with hematuria and cough. Imaging reveals a large 6.8 centimeter left-sided renal mass with renal vein invasion and pulmonary nodules. Biopsy of a pulmonary nodule reveals clear cell RCC. His ECOG performance status is 1, and he does not have any comorbidities. Laboratory findings reveal a creatinine of 1.2 with a clearance of 79.1, mild anemia, hemoglobin 12.9. MRI of the brain is negative. What would be your recommendation for management of his primary renal tumor? All right, give you guys time to answer those. All righty. Couple more trickling in, 10 people. All right, so we'll go ahead and close the poll, send those answers up. So most selected, B, consideration for delayed cytoreductive nephrectomy after monitoring initial response to systemic therapy. All right, so with that, Dr. Becks, we welcome you. Thank you so much for presenting today with us.
Yes, thank you very much for the introduction. Can you hear me? So I'm very pleased to give this talk. I also would like to thank KCA and the organizing scientific committee for having considered me to achieve this prize. I feel very honored and privileged to give this lecture now, which was initially planned to be held in Antwerp at the beginning of this year during the European Kidney Cancer Conference, which unfortunately had to be postponed. These are my disclosures. When you get an award, there's always an opportunity to sum up your work from the past. And I've always been focusing on this question, how can we improve the outcome for kidney cancer patients with advanced disease in a combination of surgery and systemic therapy? And because we have 30 minutes and we are in a session about metastatic disease, I will not focus on neoadjuvant and adjuvant therapy in my talk. We had some very good talks yesterday in the session. So I thought I'll give you an overview of historical developments, the current practice, and the future outlook. A lot of it is personal experience, but also personal opinion. And the other thing, when you get a prize, is there's an opportunity to say something about yourself. I don't know how many young colleagues are listening in, but I'm frequently asked about how do you go about building a career or a research focus? And I think all I can say about this is if you have a passion, follow it and stay put and stay focused and expose yourself to it. But looking back, my career was actually quite looped or contorted. I had my education in Germany at the University Hospital in Essen. That was finished around 1989 when the Berlin Wall came down. And then when I started, that was my medical study. When I started with my specialist training, I had to interrupt it because I was drafted in national service and found myself for a year in a field hospital in Cambodia, which was actually quite interesting. Coming back, I completed my specialization, then met my future wife, who's Dutch, and then I moved to the Netherlands, where I worked for 20 years at the Netherlands Cancer Institute. But even there, it wasn't right kidney cancer in the beginning. There were a couple of data lying around, and that's how I got interested in the field. But I also did something with transgenic mice, trying to develop a bladder cancer model, and was very often interested in working for NGOs and colleagues in Suriname, where we did stone treatment between 2005, 2008. Then I did a sabbatical in Malawi around 2008, where I actually worked a lot on the online on improving the SURTIME, let's say, protocol. And then in 2010, I was involved with Médecins Sans Frontières in the Congo. But then it got too busy, actually, to divide these things up. And I focused more and more on the clinical trials and cytoreductive nephrectomy. And this question is an important one, and it's already there for quite some time. I like to collect old medical books. I found this one in a secondhand bookshop in Berlin. James Israel was a pioneer of renal cancer surgery in Germany. So he published this book in 1901. The process of metastasis had a different name at that time. It was propagation. They were also talking about inflammation at that time. But what he basically meant is that when there was sign of metastasis, then it should be strictly contraindicated other than for hematuria or excruciating pain to remove the kidney. So when I moved to the NKI in 1999, this coincided a couple of years later with the publication of the pivotal trials we all know from Flanagan, the SWOG, and Negate EAU RCC that compared upfront cytoreductive nephrectomy followed by interferon alpha versus interferon alpha alone. And we all know the data. So there was a statistical significant difference, which amounted to 6 months in combined analysis. But this was in an era where patients would at best have a median overall survival on interferon alpha of up to a year or 18 months. And you could see in these Kaplan-Meier curves that they already dropped by 20% in the first 2 months in overall survival, regardless of whether you performed a nephrectomy or not. So to cut a long story short, we at the NKI were not particularly charmed by this approach. And we early on investigated whether the use of systemic therapy could be used to select out those patients who would probably not benefit from surgery. This eventually led to my PhD thesis in 2005 at the University in Utrecht. But in that work, I also reviewed all the literature that had stimulated us to look into this approach. And most of this literature actually came from the NCI and MD Anderson. And many of these colleagues became friends later, like Eric Jonasz, Jose Karam, and Chris Wood. And as you all know, they're also very familiar with these upfront and perioperative trials. Now, in 2006, as I think all over the world, we saw a treatment paradigm change, and TKI were introduced into the treatment in the Netherlands. And at that time, we all felt maybe we have to redo these studies. So we were contemplating redoing the SWOG and EAU RCC design, which was then eventually developed in CARMENA in France. But we actually had this idea, maybe we should follow a design in which we investigate whether deferred nephrectomy can be investigated in a randomized fashion. And this is one of the early notes I had when I went to Brussels to discuss it with the Grand Seigneur of Statistics at that time, Richard Sylvester from the EAU RCC. And I met Peter de Mulder, whose award I received for the first time during an ad board in the Netherlands. And he said, well, Axel, if you're designing these trials, you shouldn't kick out cytoreductive nephrectomy. And as you know, he's a medical oncologist, but he also was a patient. So we then continued with the development of the SURTIME protocol. We had the kickoff during the EAU RCC meeting in Cardiff in 2007. I actually went back for this talk into my office and looked at this big file, which is as thick as an arm, full of correspondence with the EU RCC about how this protocol was developed and how we improved it. And I went on and on for almost 3 years and was eventually signed off at the EU RCC Rome meeting in 2009. So you can imagine that this takes a long time. You will have to do something else in the meantime. We had a phase 2 trial of perioperative sunitinib in primary metastatic disease, which we investigated 2 months pre-treatment. And what we found is, again, here that most of these tumors, the primary tumors, shrank, but if they shrank more than 10% median and had cytoreductive nephrectomy, then the 24 months overall survival was in the range of 80%. So there was actually a very good overall survival. When I came back from Malawi in 2008, I went to the Palermo EU RCC meeting where I met Tom Powles for the first time. And Tom had done a very similar trial in the UK at Barts, the Panther trial, where he investigated 3 months of sunitinib, and we decided to pull these data together, which in the meta-analysis went into European urology, and where we looked at the outcome of these patients. And I would like to draw your attention to this part of the slide here, where you can see that patients who had an MSKCC intermediate risk at that time and clinical benefit, and then underwent cytoreductive nephrectomy, had an exceptionally long survival, which hadn't hit the median at that time when we analyzed it. But all other patients, regardless of whether they were intermediate and had a progression or poor risk with clinical benefit, whether they had a nephrectomy or not, as an overall survival which was shorter than 1 year. Again, here you can see this element of starting patients who need systemic therapy on therapy first and then deciding about cytoreductive nephrectomy later. The other benefit of these studies is that it gives you sequential tissue. We are not the only ones who investigated this, but this is work we've done together with the angiogenesis lab of Arjan Griffioen at the Free University in Amsterdam, together with Eric Jonasch at the MD Anderson, where we looked at changes in angiogenesis-related genes and the proliferating endothelial cells in blood vessels. And what you could see is that the longer the interruption time was between systemic therapy and the wait to surgery, the more likely it was that there was an upregulation of angiogenesis-related genes and also proliferating endothelial cells, which was then picked up by EBOS in a very nice comment in Clinical Cancer Research, complete with a warning that you find in the London Underground as well, Mind the Gap, which was supposed to be one of the explanations we had for this flare-up that was seen in clinics. We then went back, looked into this meta-analysis patient group that Tom and I had analyzed previously and said, is this really a clinical phenomenon? Do we observe that? So we had, because these trials were different, we had different intervals of when treatment was interrupted, and we found that there's progression during planned VEGF-R TKI interruption, which is actually quite frequent and was associated with a poor prognosis. Question, however, is that related due to the interruption or due to tumor biology? And I can already tell you that we looked into this when SURTIME was investigated. So in both arms, we had an interruption due to surgery, and the rapid progression rate was very similar in both arms. Again, we also looked into the immune microenvironment in these tumors as one of the first. This is work I've done together with Christian Blank and John Hahnen at the NKI, where we found that sunitinib treatment leads to reduction of intratumoral content of myeloid-derived suppressor cells in human renal cell carcinoma, which then allowed a better expansion of tumor-infiltrating lymphocytes that were found in the tumor. We all know these problems that although you can do expansion, these cells are still exhausted, but these led to concepts later on of combining TKIs together with immune checkpoint inhibitor therapies. Then finally, in 2010, we got the go-ahead for SURTIME, the first patients in January 2010. It was very similar for CARMENA. This prompted us together as a group of renal cancer surgeons at that time to bring out a collaborative review in European urology to create awareness for both studies, because it was very important that these trials would actually include the patients they planned to include. With this slide, I would just briefly sum up the difference between these studies. They have been presented many times already at international meetings, so I want to be very short. CARMENA basically copied the old SWOG and EAU-RCC design to investigate the role of cytoreductive nephrectomy. But in the no nephrectomy arm, cytoreductive nephrectomy was allowed at the discretion of the physician, and it was also performed in CARMENA in up to 20%. And interestingly, not because patients run into local problems, but because they had a very good response. The majority of these patients underwent secondary nephrectomy for these reasons. In SURTIME, the design was deferred nephrectomy, but only when patients did not go into progression after a predefined length of pre-treatment, which was here 3 months. There were differences in design non-inferiority for CARMENA, looking at overall survival as primary endpoint and less stringent eligibility criteria. In SURTIME, we looked at superiority, PFS, and we used the CULP factors that were published by the MD Anderson to actually select the best surgical candidates. Now, I can tell you that after 12 years from protocol development to publication, a lot of things change. You see your kids growing up. This is a photograph of myself with my 2 daughters. I have 3 children when I moved to London. And what I also found is that leading SURTIME was as difficult as trying to find your bike back in front of Central Station in Amsterdam. If you ever happen to park it there, just be very careful where you put it, because otherwise it's an impossible task. Now, looking at the results, again, I would just briefly like to sum them up because I see an overarching principle here. So both studies, in my point of view, showed that starting patients on systemic therapy first with the option to do a deferred nephrectomy as in CARMENA or a planned one in SURTIME does at least not lead to non-inferiority when compared to upfront cytoreductive nephrectomy. And in the case of SURTIME, maybe even to better survival. We found a hazard ratio of 0.57. This is a stunning improvement in overall survival. We have to be very careful here. This study is underpowered. It was downsized to a phase 2 trial, but we had a high amount of intermediate risk patients in this study. And from that point of view, I find it very intriguing that when Arnaud Méjean presented his update on CARMENA, it was a post-hoc analysis where they looked at INDC factors for CARMENA at ASCO in 2019. And what you can see here is that when you look at the group of IMDC2 risk factors, that's admittedly a small subgroup, and it was a post-hoc analysis, but you can see that the survival is almost like in SURTIME. Again, here, a hazard ratio of 0.63 and a p-value of 0.33. And this inclusion, or this risk factor situation, mirrors very much the inclusion we had in SURTIME. And again, I would like to point out that this was not sunitinib only, but it was also achieved with secondary nephrectomies being performed. And this is a quite intriguing concept. And whenever you have a situation where there is no level 1 confirmation, then you see retrospective studies popping up like mushrooms again. So in this year, we saw the publication of 2 series on deferred cytoreductive nephrectomy after pretreatment, one from our own institution and then from Danny Heng's INDC. And they both, again, point into this principle of when patients require systemic therapy, it's better to start and then revisit the indication for cytoreductive nephrectomy later on. Now, what could be the reason for this? Now, you might argue, well, there may be hundreds of reasons. There may be very sophisticated translational aspects that come into view here, but it could also be very, very simple. And this is a post-hoc analysis we did in SURTIME. So these are randomized data. And what you can see is that patients in the immediate arm compared to the deferred arm made it to systemic therapy only in 80%. And it took them longer to start, which is obvious because you had the surgery first, but also they were shorter on systemic therapy. So the median time they were on systemic therapy were 172 days until progression versus 248 in the deferred arm. Interestingly, also when you look at the spider plots here, you can see that there is this initial drop in the immediate arm when you do cytoreductive nephrectomy, which was a bit more attenuated here, and then followed deferred in the deferred arm. But what I'd like to draw your attention to is this sort of more profound control of metastatic sites in the long run in the deferred arm. And all this may be a sign of that it is much better for patients to control the disease first before doing surgery. This has led to an update of both ESMO and EAU guidelines in Europe, and was definitely said that upfront CN should no longer be considered the standard of care, but that it can be revisited depending on the success of your systemic therapy. Now, this was in the TKI era, and we all know that the paradigm has changed over and over again now. Last we heard the presentation of Nivo-Cabo, Checkmate 9ER trial at ESMO, which is now also in the treatment recommendations. So if you look at the IMDC intermediate and poor risk group, where we classically would recruit patients for primary metastatic RCC trials from or for treatment, they should now receive immune checkpoint inhibitor combination studies. And the former drugs are now alternatives. Problem is, we do not have level 1 evidence, but it's not that we don't have any evidence at all. We can say that in the pivotal trials of immune checkpoint inhibitor combination therapy, up to 30%, between 11 to 30% of patients were treated with their primary tumor in place. And the post-hoc exploratory analysis of these patients suggests that the progression-free survival and overall survival is still improved when compared to sunitinib, which was the drug that investigated the principles in CARMENA and SURTIME. So in my point of view, we do have a legacy from both of these studies. And we already see a couple of scenarios developing that we are discussing currently at multidisciplinary tumor boards. I'm sure that most of you will recognize this. I mean, the first thing is quite rare, but it has been described in the literature that there had been a complete remission of primary and metastatic sites. But in the majority of patients, we will probably now see more and more patients coming in who have complete response at metastatic sites or an outstanding long-term partial response. And then we are being questioned, what should we do with them? To illustrate this, I brought 2 cases with me, and I built them into my presentation. They're both from the NKI. That's a 72-year-old male patient with clear cell RCC, para-aortal and extensive pleural mets, IMDC poor risk factor, very poor condition. He started on Ipi/Nivo in June 2019. Then they developed a grade 3 colitis, immune-related AE. Had a complete response at metastatic sites, continued with Nivo monotherapy, but had recurrent colitis, and then was taken off a year ago. And then he was observed. If you look at the pre-treatment baseline and on-treatment scans, what you can see is the massive improvement of the pleural lesions here. It's a complete response, but also an impressive downsizing of the primary tumor. And there was this impression of ingrowth into the diaphragm and the psoas. We then underwent successful surgery. We also noticed an on-treatment improvement to 2 IMDC factors. We could say, well, he was then intermediate risk, which is interesting because we didn't see that in the old VEGF trials. And the histopathology revealed an 80% necrosis with invasion into pararenal fat, but not into psoas muscle. The other case is a 69-year-old female lady, again, lung and extensive liver mets, renal vein thrombus, IMDC 2 risk factors, was started on Nivo-Ipi, had a partial response after 4 ICI combinations and 3 Nivo monotherapies, then developed mild colitis, and then had a stable disease on continued maintenance therapy with Nivolumab. Again, here, if you look at the baseline scans, the lung mets, which were multiple, completely responded. She had a very nice partial response in the liver, which remained stable since 7 months, and a massive decrease of almost 40% of the primary tumor. And we are now contemplating to remove the primary. We collect these cases at the NKI together with the Royal Free in London and Barts, and we've collected 60 cases who were treated with Ipi/Nivo. You may be aware that Laurence Albigès investigated the same question with the Axitinib and Avelumab compound, but there are no data for the immune checkpoint inhibitor combination with Ipi/Nivo. So these are 60 patients we looked at, and we had at least 48 patients with results available on the first follow-up scan. And what we found is that the response in the primary tumors it's very similar to what we observed in the TKI era. So the bars show the downsizing of the primary tumor, and the color is coded for the response at metastatic sites. Yellow means partial response, blue is stable disease, green is complete response, and then red means progression at metastatic sites. And what we found is that when there was less decrease of the primary tumor than the median, which was around 10% of the diameter, then again, we would have more patients progressing very early on. Interestingly, it takes a bit longer for these primary tumors to respond than with VEGFR TKI therapy. We observed 6 to 9 months, and this analysis is still ongoing. So I think we will see a bit more complete responses than the 1.7 we observed here, and which does not mirror the reported results from the trials. Another good reason to actually follow this strategy is, in my point of view, supported by this translational work from Samra Turalic, which was published in Cell, where they described genotype-phenotype associations of metastasis. And we all know these patients who have these large primaries and small metastases that can be observed, or they can even be treated fully. And I would like to point out again that these patient groups remain candidates for upfront cytoreductive nephrectomy. But those patients who require systemic therapy because they have multiple metastatic sites, you wouldn't know in your office whether this is a patient who has a punctuated evolution genotype with a threat of rapid progression, or a branched evolution which would be a bit more attenuated. And therefore, a period of pretreatment is more likely to figure that out. Obviously, we need to do new trials. There are 2 trials that have been designed, and I just received an email 2 days prior to this meeting from Frede Donskop that the Nordic Sun trial has actually opened now in Scandinavia. They have the first 12 patients in, and we have the probe trial. There's another trial ongoing, which is called CytoShrink, which does not involve cytoreductive nephrectomy, but SBRT. But interestingly, for me, as a former PI of SURTIME, I think it's very beautiful to see that upfront cytoreductive nephrectomy is not standard anymore in these trials. So both experimental arms of CARMENA and SURTIME are now being investigated. So the question is around, once patients respond at metastatic sites, should we then leave the primary in place and continue with maintenance, or should we remove the primary planned and then continue with maintenance? Now, the problem with these randomized trials is, in my experience with SURTIME, and I'm sure the CARMENA colleagues will chime in, is that there may be lack of equipoise on both sides. So you can design whatever you want, but doctors may not agree with it. Patients may have their own ideas about it. And therefore, especially for surgical trials, a modern way forward could be a sort of prospective registry in which we then embed cohort-embedded trials that randomize within certain cohorts. Now, the benefit of this is, and I would like to quickly take you through this, is that, for example, you ask patients for first consent, whether they for participation to lifelong observation. You may be aware that most pharmaceutical companies are now required in Europe, at least, to register their outcomes. There may be a win-win situation. We're exploring this currently in the Netherlands. Some of them are willing to pay for these prospective registries. And then they basically enter the cohort of metastatic RCC patients. You can then focus on the primary metastatic RCC cohort and then invite them, while they are on any form of primary treatment for metastatic RCC, to consider randomization that if they respond partially or stabilize to either cytoreductive nephrectomy or no cytoreductive nephrectomy. If they do not want that, then you can investigate the barriers, but they remain in the cohort and then receive standard of care, whatever that is. You may even offer patients who have complete response a cytoreductive nephrectomy and then randomize again within these cohorts if there is consent for maintenance or surveillance. And I think this is a very modern way forward that would allow us to investigate these arms as a multi-arm design trial. And you can also do a lot of translational research with it. Now, with this, I would like to wrap up. The conclusions I take from perioperative therapy in metastatic renal cell carcinoma are, in my point of view, that patients with primary MRCC should be treated with immune checkpoint inhibitor combination with their primary tumor in place, in analogy to CARMENA and SURTIME, because there's currently no level 1 evidence that deferred CN leads to an improved survival benefit. We need trials, and these trials are ongoing, but they will probably take another 8 to 10 years. We know that. And there are quite a lot of pitfalls to be expected with this. So I think in the meantime, deferred cytoreductive nephrectomy may provide benefits for patients and should be offered in certain clinical scenarios. I would also like to thank the patients and their families who have took part in the trials we designed, also the colleagues and friends and families for their support throughout the years of my career development, and especially KCA for having awarded me this prize. Thank you very much, and I hope we have some time to take questions.
Great. Thank you, Dr. Bex, and congratulations. Again, I think we have time at the end for questions. I think we want to move forward to our next survey question. So the next survey question is: a 63-year-old male presents with hematuria and cough. Imaging reveals a 6.8 centimeter left-sided renal mass with renal vein invasion, pulmonary nodules. Biopsy of the nodule reveals clear cell RCC. His performance status is 1, and he does not have any comorbidities. Laboratory findings found creatinine of 1.2. Is this the same question? I apologize. This is the second question. A 63-year-old male has a clear cell RCC resected 9 months ago. At the time of the resection, there was no evidence of metastatic disease. He presented with fatigue. Performance status was 1, and a worsening cough. Imaging, pulmonary nodules. This is all the same question, I believe. Okay, so the question is, what would you recommend as first-line systemic therapy for the 63-year-old male? ECOG performance status 1, worsening cough, bilateral pulmonary nodules. Wait just a minute here on the results kind of trickling in. Okay, I'll go ahead and send these results. It looks like the winner here was Nivolumab plus Avelumab, followed by Pembrolizumab and Axitinib. All right, our next talk is immuno-oncology plus immuno-oncology as a first-line therapy. Dr. Olka Vishampayan.
Hi, good morning, everyone. And I was given the charge of talking about immunotherapy combinations in frontline therapy of kidney cancer. First off, I would like to thank the organizers and thank KCA for inviting me to give this presentation. Initially, I had thought I would sort of start designing my talk around the role of nephrectomy, but when I heard Dr. Bex is talking before me, I figured I better stay away from that topic. But I do want to mention that our probe SWOG trial is activating this month, so please look for it and support SWOG 1931, the probe trial that will be looking at the role of nephrectomy in the setting of immuno-oncology therapy in kidney cancer. So to start off with, of course, Checkmate 214 is our signature trial of frontline immune therapy combination only in kidney cancer. And clearly it has shown superior overall survival and response rates, as you're very well aware. Especially now at the 4-year mark, this study reported that median overall survival was 48 months, so 4 years with IPI and Nivo combination as compared to 26 months with sunitinib in the intermediate and poor risk patient population. So clearly a big advance. Previously TKI therapies alone have shown about 12 months or so.
Okay, good. Great. I think I'm on. All right, thanks.
Sarcomatoid RCC is also a subgroup to be noted within the immune therapy combination that showed a response rate of 56.7%, a CR rate of actually 18%, as compared to the overall population, it was 10% with intermediate and poor risk patients. Median survival in this group was 31 months, which again was a group that was very high risk and had significantly quick progression. So this group, specific group, is highly impacted with immune therapy combination. 30-month overall survival is 53%. The other subsets, I want to specifically mention the primary synchronous disease with metastases. So the subgroup that Dr. Bex just presented on, within that subgroup, I just want to point out that median survival in this patient population is 26 months. So much, much lower than what you see in the overall population of 48 months. So again, this group with synchronous primary tumor and metastases does need specific study in a separate clinical trials, and that is what the Nordic Sun and PROBE trials are doing. Oh. Are you guys able to hear me? Okay. I didn't know why the slides were acting funny. Anyway, okay, so the next, so I was just discussing the subgroups of IPI and NIVO, and the last one I would point out is that this is one of the big reasons of immunotherapy combinations are being considered, which is the treatment-free survival, that you can actually complete the therapy and then patients can be potentially free of disease or free of progression for some time. So far, the update from Checkmate 214 tells us that 31% of the patients are free of treatment at a median treatment-free survival of 7.8 months. For sunitinib, these are the numbers, 3.3 months, and 12% are free of therapy. So moving on to, clearly there is room for improvement, even though we have come a long way with immune-based therapies in metastatic kidney cancer, but there are a slew of other immune checkpoint activators and inhibitors that are shown on the slide. And, you know, clearly there are, as you can see, multiple pathways that we can address. So I tried to sort of put this into multiple categories, IO plus IO, of course, within that, IO plus cytokines, checkpoint inhibitors, bispecific, trispecific antibodies, and then radiation, which was discussed pretty expansively yesterday, and then other targeted therapies. So immune checkpoint plus cytokines, I'm going to present, of course, high-dose interleukin-2 single agent has shown efficacy and still remains, you know, the only therapy with the longest follow-up. Then there are newer versions of interleukin, one of which is now in phase 3 trials in advanced kidney cancer is Nectar-214. And this is a CD122 and IL-2 receptor beta stimulator to stimulate T-cell production. So the advantage of these specific receptors being stimulated is that there is a slightly higher chance of immune stimulation with avoiding or at least decreasing the risk of high-dose IL-2 type of toxicities, specifically capillary release syndrome. So here is the Nectar and Nivolumab combination data of showing pretty remarkable, promising response rates. And now there is a phase 3 trial that is enrolling currently, Pivot-09 trial, which looks at randomizing patients to receive Nectar-214 and Nivolumab as compared to sunitinib or cabozantinib, standard TKI-based regimens. The other one that I want to bring up is sort of earlier in development. This is a study that we reported of ALKS 4230, which is in combination with pembrolizumab. This study is in phase 1, phase 2 stage at this time, looking for a combination regimen. And ALKS 4230 is again a novel engineered cytokine that is created by fusing IL-2 to the alpha receptor. So again, there is selective activation of the intermediate affinity IL-2 receptors, which in turn leads to increased immunostimulation and a decreased risk of capillary release syndrome. So this study showed that this is a promising novel agent, and there was proof of principle efficacy that was seen in some melanoma patients, as well as ovarian cancer patients with the combination. So this is a preparation that may be looking at planning frontline kidney cancer trials or second-line kidney cancer trials in combination. Looking at the different other immune checkpoints that have been looked at and different mechanisms, I want to state that immune checkpoint plus metabolic inhibitors, targeted therapies, epigenetic modifiers, as well as the delivery of immune therapy by a different mechanism is also under investigation. So here are some of the mechanisms, such as formation of tumor reactive cells and activation of effector T cell function, which may end up giving us clues as to which treatment is likely and should be taken forward in the phase 2 setting. So clearly, with all these slew of treatments, preliminary studies are essential to then making a decision. And hopefully, if we have surrogate biomarkers, which we may start seeing a glimmer of hope about getting those to be able to identify early on the responders or people who benefit from frontline immune combinations. And the different strategies are vaccine combinations as well as immune checkpoint inhibitor combinations. And then, of course, T cell therapies are under investigation, and multiple T cell agonists such as the cytokines and OX40, et cetera, are also under investigation. The other one that I want to bring up, which is an area of active study, is things like the CD47 antibodies. So macrophage immune checkpoint inhibitors is an area of active investigation in combination with other PD-1 inhibitors. Bispecific antibody approach is also under study. There are clearly bispecifics of CTLA-4 and PD-1 that are currently in phase 2 trials. And then there are multiple other ARM T cells with bispecific antibody approach that we have been studying also. So I want to conclude with this checkpoint therapeutic target database. This is for the first time there is a comprehensive database for checkpoint targets and their modulators in cancer immunotherapy, with actually an efficacy score that helps you determine where things are in their development, as well as how those should be moved forward or not, depending on the preliminary data that is seen both in the preclinical and the clinical trial setting. So to conclude, I would say that immune checkpoint combinations have demonstrated tremendous promise in advanced renal cancer. Now we have a median survival of 4 years and ongoing durable responses are seen. PD-1 inhibition is basically now considered the backbone of future combination regimens in RCC, and that is a position well earned, frankly, with all of the frontline studies that we've seen. Immune checkpoint and cytokine therapy combinations I showed you are being evaluated in clinical trials, and then multiple other immune checkpoint inhibition combinations are being studied, and then macrophage immune checkpoint inhibition by tri-specific antibodies are under investigation. The last point was novel delivery techniques for immune checkpoints for selective release at the tumor cell, which of course would be a godsend, given that especially if we can avoid a lot of the immune-related adverse events, which tend to sort of affect our patients, not just during the treatment, but even affect their life after the treatment is discontinued. And with that, I will stop and thank you for your attention.
Wonderful. Thank you so much for that wonderful presentation, Dr. Vishampine. So next up will be Dr. Suzanne Cole. She'll be presenting on tyrosine kinase inhibitor and immuno-oncology as first-line therapy. And before she starts her presentation, we'll actually do our third polling question. Send this to everybody. It's our same case, but a little bit of modification of his risk criteria. So we'll go through this. 63-year-old male with clear cell RCC resected 21 months ago. At the time of resection, there was no evidence of metastatic disease. Surveillance imaging revealed multiple bilateral pulmonary nodules, which on biopsy were found to be recurrent RCC. His performance status is 0. Laboratory abnormalities are normal. His MRI of the brain is negative. So in essence, this is a favorable risk patient. So what would you recommend as first-line systemic therapy? All right, hopefully get more people filling out the poll here. All right, very good. All right, we'll send the results out to everyone. Looks like the majority of individuals selected the combination of pembrolizumab plus axitinib for this patient. So Dr. Cole, take it away.
Good morning, everybody. Thank you all so much for getting up early to talk about IO-TKI as first-line therapy for metastatic kidney cancer. So my name is Suzanne Cole, and I am a general medical oncologist. I am a jack of all trades, and I do a little bit of everything, but I love taking care of kidney cancer. I work at UT Southwestern in Dallas, and I'm going to talk to you today about the challenges of IO-TKI and getting these drugs to our patients in the community setting. So as you know, there have been a lot of combinations that have been in trial, and some of these have been FDA approved. And I'm really going to focus on the two combinations that have an FDA designation in the United States, as well as Cabozantinib and Nivolumab that hopefully will get their FDA designation in the coming year. So the first combination is Pembrolizumab-Axitinib, and this was based on the KEYNOTE-426 study that used the metastatic frontline patients with clear cell renal cell carcinoma. These were stratified based on favorable, intermediate, and poor risk disease. They went into Pembrolizumab and Axitinib versus Sunitinib. And this is data that was presented at ASCO this summer by Dr. Plimick. We have overall survival data for 30 months. We can see information based on the 12-month mark where the Pembro-Axi arm had a 90% overall survival at the 12-month mark versus 79% in the Sunitinib arm. At 24 months, that was 74% in the Pembro-Axi arm versus 66% in the Sunitinib arm. And the overall hazard ratio was 0.68. And at the 30-month mark, Pembro-Axi still has not reached the median survival, whereas Sunitinib is at 35 months. Avelumab and Axitinib also has an FDA indication for frontline metastatic renal cell carcinoma based on the Javelin Renal 101 study. These patients also were frontline metastatic renal cell carcinoma with a clear cell component. All of these patients were randomized to Avelumab and Axitinib, as well as Sunitinib. And the entire population was tested for PD-L1, but regardless of their PD-L1 status, the entire population had a benefit from the Avelumab and Axitinib combination with a progression-free survival of 13.8 months versus Sunitinib at 8.4 months. And the hazard ratio for disease progression or death was 0.69. And this also got an FDA indication for frontline therapy. So the third combination was recently presented this summer, is Nivolumab and Cabozantinib, Checkmate 9ER. These are also upfront frontline metastatic renal cell carcinoma patients. Any risk group was randomized to nivolumab and cabozantinib versus sunitinib. And although neither arm has overall survival data, at the 18-month mark, we are seeing that there has been a 40% risk reduction in death, and the hazard ratio is 0.6. And so this has received a priority review for the FDA, and we are hoping that this will receive an approval within the next year. So given this information, as well as the information that was presented by Ulka, I wanted to take this opportunity to just put this information together with the IO-IO combinations, as well as the IO-TKI next to each other so that you can kind of see the data side by side. Now, Ulka just mentioned that we do have 4-year overall survival data for Ipi-Nivo, and we do have long-term information about Ipi-Nivo. The IO-TKIs are newer drugs, the trials are much younger, and so we don't have a lot of long-term information. It is interesting that the IO-TKIs have a 12-month overall survival that is between 6 to 10% higher than the Ipi-Nivo, which is somewhat interesting. I think that the hazard ratio for that first year is about equivalent and hard to interpret. But definitely there is progression-free survival that is in favor of the IO-TKI combinations. The overall response rates are much more significant in the IO-TKI combinations. However, in the Ipi-Nivo IO-IO combination, there are these very significant and deep responses that are very long-lasting, and there's this cure fraction, which is kind of the holy grail that all of us want for our patients. And it's not clear that in the IO-TKI fraction whether that's something that's happening. Also, the adverse effects, we have to think about when the patient is in front of us, what combination of drugs is appropriate for the patient. All of these combinations have an immunotherapy component, and so there's always the danger of a severe immune-related adverse effect. However, the Ipi-Nivo combo, when you're in the Ipi phase of things, that's when the very severe immune-related reactions occur. But once you're past that phase and you're onto the nivolumab maintenance, it's a much better quality of life for the patients. And there is a chronic toxicity that comes with the TKI that is not trivial to these patients. So definitely something to keep in mind. So the other toxicity that really is harrowing to me and to my patients is the toxicity of cost. And I just wanted to highlight to everyone the sobering fact of how much these drugs cost. This is public information. I pulled these numbers off of UpToDate. This is a 1-year estimate based on the published trials of how these drugs are given if you were to calculate a 1-year course for a 70-kilo patient. So these drugs cost between $300,000 to $500,000. And if you have excellent health insurance, that's fantastic, and you may not have to pay anything. But a lot of my patients have copays that range between 10% to 20%, and that could be $70,000 to $100,000 that patients with stage 4 cancer who may not be able to work are having to come up with this kind of money, and it's outrageous. And also when you're thinking about the TKI component, which is an oral mechanism that is sometimes much more burdensome to the patient, it's very hard to get these drugs actually into the hands of the patients. And I wanted to highlight this paper that I came across. It was published about 3 years ago, which was really kind of more in the sunitinib years, which was highlighting how unaffordable the copays and deductibles are for patients who have insurance, and that a lot of patients with kidney cancer are spending somewhere around $25,000 out of pocket on their copays to get oral medications to treat their kidney cancer. So this is a graph highlighting Medicare patients that were stratified into low income versus high income Medicare patients. And the low income patients had a subsidy that knocked their copay for oral chemotherapy medicines down to $7. And those who were considered wealthy Medicare patients had to pay $2,800 per month for their oral chemotherapy medications. And, you know, as you would expect, those who had a $7 copay were much more likely to fill their medications within the first 200 days of receiving their prescription. But if you had a $2,800 copay on your oral chemotherapy medications, it was very unlikely that you would actually fill that medication within the first 200 days of receiving that prescription. And so the point that I want to make with this is that even though we have these amazing trials where we're giving free drug to our patients and proving that we have these huge survival benefits, if when these drugs come to market, they are so expensive and the copays are so high that the patients who have cancer cannot actually get the medications, it doesn't matter. It doesn't matter how great these drugs are at working. If they can't get to the patients, we're not being effective. And so if pharma is listening or the government is listening or our healthcare organizations are listening, we have to do something to lower the cost of these drugs or our patients are going to die. And all of the work that we're doing to improve survival is meaningless. So the cost is a huge, huge burden that we have to work to overcome. So overall, when we're looking at IO-TKI as our frontline drug, we have to think about the pros of these have good overall survival. They have huge response rates and these long progression-free survivals. The side effects are manageable and they don't have these outrageous immune-related side effects that are very scary with Ipi/Nivo. The cons is that you're not totally sure about the durable overall survival. The high cost is obviously a real worry. Insurance barriers are a huge problem. These are young trials. We don't have long-term follow-up. And then what is the end game? Are people supposed to stay on these drugs forever? What do you do second line? You've already used a TKI. You've already used immunotherapy. You've used both of your drugs up front. What do you do as the next step? There is this lower quality of life because of the chronic TKI toxicity. And then you're also not sure which drug is actually working, and you're not always 100% sure what the toxicity is and where it's coming from. So those are some downsides. So in conclusion, clearly we have multiple options already available to us. That beginning slide shows that there are a lot of other combinations coming our way. I would say that the winner that's going to take the lead is probably going to be the one that is the most affordable option, at least in the United States. And I really look forward to the discussion that's coming next. Thank you guys so much.
Wonderful job. Thank you so much, Dr. Cole, for that excellent presentation. And then we're going to be
next up, we're going to move to a Q&A session for discussion of first-line therapies. In the box for all the audience, there is a Q&A box in the bottom left side of the screen where you can type in questions for anyone on the panel. So one of the first questions was, how are the guidelines, or how do you modify treatments for patients with non-clear cell renal cell cancer?
I guess I can take that if. So I think for non-clear cell kidney cancer, the problem is, you know, all of these studies that we presented did not include those patients, and frontline therapy is still being sort of standardized. There is pretty much most of the evidence points towards using frontline TKI-based regimen for non-clear cell histology. There is a PAPMED study that has been completed by SWOG, and the results are awaited, which looked at different MET inhibitors in papillary kidney cancer. So there should be more to come on each of these studies, but as of now, I think a TKI-based regimen is the most evaluated.
Great. Certainly feel free to turn in your questions. I have another question for our panelists here. I think we all struggle sometimes with our favorable risk patients, exactly what to do for those individuals. Maybe if each one of the panelists can comment on what is their approach to a favorable risk patient and thinking about what's the best systemic therapy for them.
Dr. Bex, do you want to go first?
Oh, sorry. Yeah. I mean, we obviously discussed this as well. So before we had the data of Pembrolizumab-Axitinib and Nivolumab-Cabo, we still felt that sunitinib had a place for those patients who are favorable risk. And if you look at the data as they mature of Pembro-Axi, there may still be an argument to continue with sunitinib monotherapy in these patients. The problem is currently that, if you look at it from a guideline perspective, you can only give recommendations based on the way the studies were designed. And Pembro-Axi, for example, was an ITT design across all risk groups. So in exploratory analysis, you can take these risk groups out, but it does not necessarily mean you can take that as a guidance in clinical practice. I still think in the Netherlands there's a divide. Some feel patients should be offered Pembro-Axi, for example, or Nivolumab-Cabo if that becomes available, and others still feel that sunitinib or pazopanib is a good reason or a good option.
Suzanne, do you want to go?
So I like to try trials, and so I have Pedigree open, and I try to offer that to my patients. That's my first line.
I would also say that, if there's a clinical trial open, that is what I'm going to be recommending. And Pedigree is a perfect study for across the board favorable, intermediate, or poor risk patients. In the absence of a trial, I think, there are some patients within favorable risk. I think there is a dichotomy of patients, so to speak, that there are some who are very, very slow progressors who are on surveillance for quite a while. Those, if I decide to treat them, I may consider single agent TKI at that time. But majority of the ones, and definitely the ones who present with synchronous primary and metastases, I have been leaning towards going with an immune-based regimen just because we saw that even with that, the outcome is not the greatest in that patient population.
Great, thank you. For Dr. Bex, when do you think about cytoreductive nephrectomy in the current era? Are you doing it more frequently up front, or how are you kind of thinking about it? In which patient do you offer cytoreductive nephrectomy up front?
I think very important. I think it's an important question. So I give a lot of talks about this. We try to say that the most important decision-making process here is probably your multidisciplinary team discussion. If the oncologists feel that this patient is better off having systemic therapy rather than, for example, it's exactly what Olga was just alluding to. You have these patients who have large primaries. They have just a few pulmonary nodules. They're too small to justify starting systemic treatment, but they're too many to resect. And we actually published about this. We had a series of 40 patients, so you can do an upfront nephrectomy and observe them. And the time without therapy was about 1.5 years. So having said that, I think this is the biggest criterion. So if oncologists feel, or we as a team, there are multiple sites, they're intermediate risk. It's not so much depending on the risk score. It's just, I think also just common sense, and they should be put on systemic therapy, then I would not advise to do an upfront cytoreductive nephrectomy. And if they then respond later on, these drugs are quite expensive. I think a patient who could be turned into no evidence of disease if they respond should be given the benefit of the doubt, and it should be done, unless there are clinical reasons of high risk to perform the surgery.
Thank you.
That's great. And it's kind of a follow-up, but for the entire panel. So cytoreductive nephrectomy can have two large lines of benefit. First, a potential survival benefit, which we as cancer doctors tend to perseverate on and focus on exclusively because it's easier to measure. But in some patients, surgery may improve their pain, systemic symptoms, hematuria, those things. So first, and you spoke a little bit to right now, how are we taking care of these patients right now, but how can we study these patients better in the future? Because a lot of them will get an upfront cytoreductive nephrectomy for symptomatic reasons.
So that was a question to me in terms of when patients present with symptoms.
Yes.
Yeah, I mean, well, thankfully, these are very few patients. I think it's very important to look at what the symptoms are. If they are really related to the primary, then obviously you can start the cytoreductive nephrectomy. You can do that. You also have other options, certainly if it's hematuria, if it's not so much pain related. I have to admit that in my practice, looking back in the last 4 or 5 years, I had maybe 1 or 2 patients who would be having symptoms because of the primary, local symptoms. And if you want to set up a trial for this is, I think, even more difficult than any other cytoreductive nephrectomy trial because these patients are not around there. I would probably give them, again here, the benefit of the doubt, put them on systemic therapy. Maybe if the treatment are, I would then also use an immune checkpoint inhibitor combination with a TKI because they're considered to be a bit more responsive in the primary and take it from there. But frankly, I wouldn't have a good advice to you. But I've seen quite a few patients, if they undergo surgery, in the recovery phase already developing rapid progressive disease, and then you have another problem.
So Dr. Bex, we have this really interesting phenomenon in Texas. I work with Dr. Margulis, who seems to know every urologist in Texas. They all have his cell phone number. And whenever somebody walks into a local hospital in the middle of nowhere with a huge kidney mass and an IVC thrombus that's, eating into the atrium, they call Vitaly and he says, send them over, I'll see them tomorrow. And then he knows I'm in clinic every day. And so somehow I end up with these patients, and we seem to have like 1 or 2 every month of these crazy, very advanced kidney tumors. And we have been running into very difficult problems of the financial problem of getting drugs approved to try and cytoreduce these patients so that we can convert them to a surgical, to try to cytoreduce them. A lot of these patients have pain, they're passing blood, there's difficulty, and we've had such difficulty gaining access, mostly because we live in Texas. We didn't expand Medicaid. People have various states of insurance or lack of insurance. And so we've actually written a trial and tried to obtain pharma funding so that we can do an IO-TKI combination in a neoadjuvant way to get these patients to surgery. It's not prime time yet, but if we can get it together, we're hoping to even bring it to the co-op groups because these people are out there, and I think this is an unmet need that may be able to be addressed.
Yeah, sure. I mean, if the numbers are there, then I think then it would be a good idea to give it a try. Do you have any retrospective data? I mean, what is done with these patients currently? Are they currently undergoing surgery straight away? And what is their outcome without treatment?
It's not, we don't have like a lot of data, but we probably have 20 cases a year, and some of them are getting neoadjuvant treatment and some of them are going straight to surgery. But yes, like it's happening for sure. And then I have friends in Oklahoma that have like similar numbers, maybe like 10 cases, because they're out there and there's aggressive surgeons. So So definitely we should pool our numbers.
Yeah. I wonder, yeah, I was going to say, I wonder, technically the trials enrolled locally advanced unresectable and stage 4. So you could conceivably categorize somebody like that as locally advanced unresectable, and they're just getting the best frontline therapy and then, converting them thereafter.
But I've had insurance deny coverage because they are technically stage 3. So it's so crazy. They have internal guidelines that they'll use because these are expensive medicines. And so it's not in an insurance company's best interest to approve these drugs, right? So it's crazy what we have to put up with,
That's very challenging.
Yeah, I think we see the same population as far as at least 10 to 15 patients like this a year.
So that's what I feel like. If we pool our numbers, these people are out there.
Yeah.
I'm glad you've written a study, though, so that will give us some data of neoadjuvant therapy in these tumor thrombus, unresectable, prospective data, which we haven't had all this time.
Right.
One other question, going back to the first thing, when we talk about favorable risk, it seems that just about anybody or almost anybody will be deemed intermediate risk just because the subjectivity of whether or not they need to be treated. So it's always very interesting to me when we talk about the favorable risk patient, because the favorable risk patient probably had a nephrectomy 3 years ago, right? Can you guys speak a little bit about that?
Well, I should start from, I think it's good that you bring this up, Jason, because when a patient presents with primary metastatic disease, so synchronous metastatic disease, you will only know if they have favorable risk, if they don't have any other factor and they don't make it to therapy within a year. So if you take, for example, if you do upfront nephrectomy and then you observe them and the time they cross the first year and they don't have anemia or anything else, then you could retrospectively say, well, they had favorable risk. But that is really, really difficult. So I think, yes, also in Danny Heng's series, I always find it very interesting that you see that the more Mozart's concept, but what he designed in the initial MSKCC validation cohorts, they had about 45% with primary metastatic disease in them. And in Danny Heng's series, I think the last validation series only contained 17% of patients with primary metastatic disease. So most patients actually have metachronic metastatic disease, and it's much easier to design this.
As a follow-up question to Dr. Bex, with now all of these novel therapies and combinations, what does it look like when you're doing your cytoreductive nephrectomy? Is it all fibrotic, far down? Is it easier? Is it harder? What is, from a surgical standpoint, how does that modify your approach? And sometimes I know that that's been denoted.
Yeah, I agree. I mean, I remember that, I think it was 2 years ago at ASCO, someone from the audience stood up and said it was so difficult to do surgery on these patients. It was almost like RPLND after chemotherapy for seminoma. And we do know this. I mean, I also had occasional patients where it was very difficult. We have a neoadjuvant trial ongoing with Axitinib and Avelumab. I can't disclose too much about the results yet, but I can tell you that only a minority of patients have very fibrotic tissue layers. So it's certainly something that occurs, and that had also been described in a French series in 11 patients that have been collected. But I don't think that if you look at it as a group to start from, that this is something that always happens. And we've done quite a few deferred nephrectomies in retrospective series now, which are presented also in the UK now. And many of these patients are just ordinary nephrectomies. I wouldn't be able to say that there's a big difference between them.
Got it.
But it does certainly exist.
I do have a question. Do you find that when people have had TKI, do you have higher incidence of thrombotic complications in the perioperative setting?
That's not something that we had seen in SURTIME. So we looked at that. Again, we have to be careful here. We're comparing 50 patients per arm, basically. But in fact, it was more the intraoperative complication rate, which so we used the Clavien-Dindo for postoperative ones, but blood loss, for example, was higher in the non-pre-treated ones. And there had been publications out there before that said, well, it increases tissue layers and fibrosis, but with 3 months of pre-treatment, we found very often edema, and edema was very easy to do surgery in because it is already a fluid-filled tissue layer, and there was a lack of blood vessels. So that might, in comparison, explain why we had fewer patients with intraoperative blood loss as compared to the untreated ones. But I can't say that we had more thromboembolic complications. Not even wound dehiscencies or something like this, which was mentioned.
So I agree with you. I do not think that surgery in general has been much more difficult. I would say 95% of them, I have not seen a terrible reaction to any of the newer therapies. One question is, as more people are treated with upfront systemic therapies, and the patients have a good response or stable disease within their chest and their other sites, we're seeing more and more people back. So when, and this is really for the medical oncologist on the panel, when are you seeing a patient that you decide that it's a good time now to get the primary tumor out? What is the timing of the primary tumor that you would recommend?
When they're stable, like when we're thinking about taking a break from therapy, when their health is good, like I'm always assessing that personally.
So would you say at 3 months, 6 months, a year?
I'm kind of doing it at scans and reassessing, and I lean towards I want it out because I just have a personal belief that the less tumor that's in the body, the better for the patient. So despite the CARMENA data in the individual patient, I'm always looking for that opportunity if the patient is well and fit. That's my personal bias.
I must say I haven't automatically considered them for surgery if they've gone into remission with systemic therapy because, I feel like, is there really, first of all, viable tumor, and is that tumor playing a role in future progression? And we don't know is the real answer in terms of evidence. But I have tended to sort of not do a nephrectomy unless they got symptomatic.
I think I can chime in. I think I wait at least a minimum of 6 months, and usually by that time they've gotten at least 2 scans under their belt, and then I'm coordinating the joint visit with urology, and so then usually it ends up being between 6 months to 1 year, but making sure that you have a couple of scans where the patient has actually demonstrated hopefully an actual response, and before we actually decide to pull the trigger on doing the nephrectomy.
It seems like there's a real heterogeneity of responses out there. And I think it's interesting because as surgeons, we like to operate when people are doing well. And if you wait until somebody is doing poorly symptomatically again, I think we're less excited about operating on those patients. But I think that's something that, maybe hammering down some endpoints or some, ideas for future study could be fruitful.
I think I would argue that, if they're feeling well on the systemic therapy, is the surgery going to add anything? And that is the question I would ask before, can you do it? Absolutely. But is it going to make an impact on the patient's tumor and their overall life expectancy, et cetera? That, I think, is the bigger question, which hopefully the studies will answer. But, right now it's very controversial, as you saw.
I also believe that, these 2 studies that are currently set up should be ideally placed to answer this question. May I just ask you, if you have the time, the opinion of the medical oncologists as well, if you do have a patient who has complete response at metastatic sites, obviously there's a good argument to remove the primary. again, it's not proven that it changes anything, but I think we all feel that would be a good idea to do. How would you then feel? Would you dare to stop therapy afterwards, or would you feel more towards inclined to give maintenance? What are your arguments for that?
I'm all for stopping therapy because of the toxicity, and like, we can't pay for this forever again. Like, that's a big problem for me and for my patients. And I don't know, I just live in a world personally where the payment is a big deal for me and for my patients. And it's something we're dealing with often. And sometimes my patients stop therapy when they need it because they can't afford it anymore, or their insurance cuts them off, or they lose their health insurance. And because of COVID, right now, I've had many patients who have lost their jobs, are in the process of losing their health insurance. They are falling off of our schedules. And this is just going to, you know, when we have an opportunity where there's no evidence of disease, I think that is a very valid and fair time to stop these very expensive drugs. And we always have the opportunity to restart them if there is progression. But I understand the fear as well. But we don't know what we're treating when there's nothing there.
I agree. I'm very much also in favor of at least having a discussion and considering for those patients who have complete response. And especially after the primary is removed, I would say, yes, absolutely. And I have a number of patients who, even with the primary left in place because it wasn't progressing and had responded very well, I've been able to stop therapy and put them on surveillance. So we absolutely need some timelines on the therapies. I mean, currently Axi-Pembro looked at 2 years as a maximum duration, but there is studies ongoing and looking at what is an optimal duration after a response has been achieved. Clearly, it's a good problem to have, but we do need to optimize that.
Yeah. So thank you so much to our panelists. Wonderful presentations this morning, Dr. Bex, Dr. Cole, Dr. Vishampayan. We're going to segue now to our international considerations panel. We are so excited to have these esteemed physicians joining the discussion today. Dr. Laurence Albagies from France, Dr. Guillermo de Velasco from Spain, Dr. Masha Tioshi Ito from Japan, Dr. Andre Fay from Brazil, and Dr. Victor Grunwald from Germany. Why don't we have each of you go ahead and introduce yourselves and to what your specialties focus on and the type of patients that you see in the clinic, and highlight just some of the unique considerations in your individual countries, and then we can do some questions. Dr. Albagies, would you like to start for us? Okay, Dr. De Velasco, would you like to start for us?
Yeah, sure. So, hello, everyone. It's a real pleasure to be here. Thank you very much for the invitation. So I'm a medical oncologist based in Madrid. I'm focusing in genitourinary tumors. So I do kidney, I do bladder, and I do prostate cancer. And based on thinking how different are in Spain, I think the previous talk has been quite interesting about financial toxicities and the issues about access to drugs. Because in Spain, we have the access based on the EMA. So we get the approvals based on the EMA, but then we have our own Spanish health agency who is approving the drugs. So we have a national system. So we get the approvals for the whole Spain, but then we have some challenges because we have 17 different regions in Spain. So each region can get different approvals for different drugs. So at the end of the day, it's a real mess what options you have and which options can you get in kidney cancer. And I find something quite interesting regarding which options we have available. So the first thing is that, obviously, for example, if you think now in Spain, we don't have approved or we don't have reimbursement for Ipi/Nivo or any combinations. But if you ask me what I'm doing for patients with intermediate and poor risk, I'm treating those patients with combos because we have other ways to get combinations. And here I'm asking, or I'm putting one concern about, there are two different things. One is, what do you have access with the guideline, which is providing general guidelines to get drugs approved. However, we should think about getting something else, such as essential drugs. So which is the minimum drugs that our patients with metastatic kidney cancer should be offered at some point regarding the evidence that we have today to treat our patients.
Yeah, I'm going to follow up on you. Thank you very much for the kind invitation to the KCA. It's great to have this panel discussion. So actually the situation in France is that we do have access and reimbursement. And with regard to what Dr. Cole was mentioning, we actually have full reimbursement by our national coverage, both for Nivolumab and Ipilimumab, as well as Axitinib plus Pembrolizumab. So we have access to 2 combination regimen in all our patients, as long as we fulfill the label criteria, of course. And this is what we are using. My feeling is that in the country, we tend to have patients being referred to academic centers so that they can also be part of clinical trial, many of which are open both in Europe, in the US, and in other countries. And with this regard, we'd like to develop a strategy trial. This is what we do. Titan RCC to see if we need to have upfront combination or some trials based on biomarker. And this is what the Bionic trial presented during ESMO was trying to achieve as well. So we are fortunate to have access to combination regimen, and we have a full reimbursement for that. But sometimes we get some delay in this reimbursement, and sometimes it's only after 1 year when compared to EMA approval that we get the reimbursement for accessing these drugs.
Thank you, Dr. Algy.
So hello, everyone. I will follow my friend Laurence Albiges. My name is Andre Fay, medical oncologist from Brazil. I'd like to thank you the kind invitation. It's a great pleasure to be here in the KCA and bringing some of our reality, from Brazil, a developing country, and the challenge is probably a bit bigger, when we don't have resources. So in Brazil, we need to think that we have 2 different systems. We have a public system and we have a private system. And 70% of the Brazilian population are in the public system. And we still don't have sunitinib or pazopanib to give in the public health system. It's really hard to treat patients with metastatic RCC in the public setting. That is the largest proportion of patients in the country. So we are still struggling, to have access to these drugs. We have sunitinib and pazopanib incorporated in the public health system 2 years ago, and we still don't have the policies, how we are going to afford that. So it's really, really difficult. So when we think on the public health system, we try to use clinical trials to treat those patients. So in my practice, and I work in academic and in university hospital, we have clinical trials, and we put all those patients with metastatic RCC in clinical trials as we can. So this is and also an opportunity for all of us, trying to put patients in trials and contribute with the international and multicentric clinical trials. When we talk about the private setting, I think we have, similar problems, worldwide. We still have different problems in terms of approval. We have different steps of approval when we talk about IV drugs or oral drugs. So it's easier for us to have IV drugs approved. When we have oral drugs, we need we have more than one step, of approvals to get these drugs for patients. So in my practice, it's easier to use Ipi/Nivo, for example, for patients with intermediate poor risk patients than use TKI combos, because the health insurances usually don't want to afford and to reimburse for the oral drugs, and we are just talking about cost here. And I believe that the points that Dr. Susan Cole brought up in her presentation. It's really, really important and matters a lot when we are working in a developing country. So it's a big challenge, for us to treat the metastatic RCC patients, but we still have access to those medications. Those combos have been approved here, but we still need to find a way to provide this medication and to have access to these patients. And the last thing is that now the health insurance companies are trying to have their own protocols. So the health insurance are saying to the medical oncologist, okay, this is the protocol that I use for my patients, so you need to use this protocol to treat your patient. And sometimes physicians don't have the choice, and they need to use, for example, Ipi/Nivo or Pembro/Axi based on the decision that were made by the health insurance companies. So it's a big challenge.
Thank you. Dr. Ito, would you like to talk about your experience in Japan?
Hi, I'm Professor Eto from Japan, and I'm a urologist. And in Japan, urologists mainly prescribing kidney cancer drugs, because medical oncologists dealing with genitourinary cancer are very limited in Japan. So Japanese urologists do both surgery and medical treatment. So we are very busy. And regarding health insurance, in Japan, all Japanese citizens are covered with health insurance system. So we can use all patients if the drug is covered with health insurance. And now in Japan, Nivo-Ipi, Pembro/Axi, and Avelumab-Axi, and Cabozantinib are available. And Nivo-Cabo is not yet. It's a Japanese situation. Thank you.
And Dr. Grunwald, would you like to share your experience in Germany?
Yeah, thank you first of all for the kind invitation to share my point of view from the German perspective. So I think, we're in a very comfortable position where we have no limitations in terms of access, because once we have EMA label for a given drug, it will be available in Germany in due time. So there's no postponation, actually. So we think this is a better position to offer patients the most advanced treatments and without any delay. However, how it's being set up is that there are price negotiations that will take place 1 year later, and it will affect the companies and the health authorities really to come up with an appropriate price given on the benefit the drug is providing to a given patient. So I think that's, from a patient perspective, very good news. When it comes to who is offering this type of therapies, we have a very similar situation as in Japan, because we do have a lot of organ-confined or specialized oncologists, which leads to the fact that we have urologists also having this offering this type of therapy, and medical oncologists at the same time. However, there is some sort of qualification steps that have to be accomplished by somebody who is not trained in medical oncology in order to provide this type of therapy. So it is a bit different when it comes to the type of, how within the whole of the country, the type of therapy is being delivered by the different specializations.
Thank you for that. Thank you for all of the panelists for sharing their experiences. So maybe we'll go through some additional questions. For all the panelists, is there opportunity for use of IO combos post first line? And do you have that opportunity, or is that not something that is available to be done?
So Reina, I'm going to start. We clearly don't have this opportunity, unfortunately, outside of clinical trial. We cannot offer any combination.
Yeah, I think in Spain happens the same. We don't have any options to use any combo at second or further lines. The only options that we have currently is to include patients in clinical trials as well.
Same thing in Brazil. We are still trying to use clinical trials as the best option, for patients. We still have, a very, very small proportion of patients that are able to pay privately and use some off-label treatments, but this is not the reality. And I think it's similar to the other countries.
In Japan, we can use IO combo only in the first line. We cannot use later phase.
And it's the same thing in Germany. We kind of bound to the license of a given drug or a combination. And there are some possibilities to get access to, but that would include phase 3 clinical data in hand. So once we have that, there's also a possibility to bypass the license process because it is some sort of delayed until it actually hits the market.
Does that at all augment, thank you, does that at all augment your choice? Just thinking now with some of the long-term data evolving from Nivo-Ipi, the durability of response, depth of response, and possibility even, cure, should we even say it, does that at all augment your choice knowing you don't have an opportunity for a combo later?
Thank you, Reina. I think it's an important question, and I'm sure we actually don't have great data to answer this specifically, as we don't have studies that are addressing this point. I really feel that the first line for the moment is where the focus is with regard to combination, but there are several trials up and running in second line or starting right now, which ask the question of sustained PD-1 inhibition, for instance. So we'll know more. I think one of the questions we're facing is that in first line, should we have a strategy of intensification or de-escalation? And because we don't yet have any biomarker that we are routinely using to select our strategy, we're not yet able to guide the patient toward one or the other option, combination or single agent. So my feeling is that for the moment, we will stick to combination in first line. And with regard to subsequent line, we're sequencing with the agents available. But unfortunately, we do know that usually it doesn't put our patient in CR and clearly may not have long-term OS benefit, unfortunately.
Yeah, I would agree with Logan's in this topic, because if we think what's happening in second and further lines, so we are not seeing anyhow the results that we've seen in first line. So with the combinations, we are getting really, really long durable responses for many patients, and that's pretty good. For example, the data with the CheckMate 214 for years, those PFS, we are not getting those data in second or further line. So one of the points is it's really difficult to get combo at first line, so it's going to be even more difficult to get at second line with less important results or less evidence. And even though you think, for example, data with Ipi-Nivo, so the data with Ipi-Nivo after immunotherapy is not as good as the first line. So definitely we should focus on, as I mentioned before, okay, try to get the best combo for our patients, and probably the best combo, any combo, is going to be in the first line.
Completely agree with my colleagues, and I believe that they're in.
I can hear you, Andre.
Okay, I'm sorry, because there was a problem here. But okay, I'm sorry, guys. But I'm completely agree with the colleagues, and I believe that we still don't have a strong evidence about the the combinations and how to select patients for for different treatments in further lines. And I believe that the stronger data that we have, with best efficacy data, is to use the combinations in first line. So I believe that's the thing that we need to follow, and it guides definitely what we try to do with our patients.
Basically, my opinion is also same as previous guys. And in Japan, probably Nivo-EP has longest experience. Every Japanese urologist has the longest experience. So after Nivo-EP, we have good data of TKI, but so far we don't have so much data after IO plus TKI combo. That's the current status.
Yeah, and as for me, I mean, I like to give the best treatment option to a patient in a given situation. So I don't think in sequences, because your patient may not get it, because he may not succeed to the second or third line. And so therefore, I think, we're currently facing an episode where we have treatment intensification. So we now established doublets as the primary approach to patients. So there may be a chance that we see triplets coming in the future. But as Laurent said, what about de-escalation? Does it work as well? And I think in order to do that, we have to have a better understanding and have a proper biomarker that really tells us where to de-intensify and where to put the pedal on the gas and have more intense therapy in patients.
Thank you.
Let me say, just a quick comment here that I believe it's important, because when I look to the data from Brazil, there is a small proportion of patients that achieve a second or third lines. So when we compare this data, with data that we have from US or Europe or other parts of the world, we still see a very, very small proportion of patients that could achieve a second line. And we don't have, a explanation for that, but probably the patients, are arriving late, or the diagnoses are being late. And so patients are more fragile, or, so this is another thing that makes us use the best option that we have in first line.
Great. So segueing a little bit from Dr. Bex's talk and some of the discussions that we had earlier, for our panelists here, when and where do you integrate cytoreductive nephrectomy, and what are some of the challenges, if any, that you encounter within your health systems regarding surgery for these patients?
Thank you, Reina. Well, first, I'm very excited that Axel got this recognition for all his work, and I really enjoy his lecture. In France, because we're the country of CARMENA, we clearly integrated this strategy in our guidelines. And what we do is we start in a patient who requires systemic treatment. We start with systemic treatment, and it's only in patients who achieve great response that we consider delay cytoreductive nephrectomy. Usually we tend to consider that in the range of 9 months to 12 months, to answer Jason's question earlier today. And if the patient is put in NED, and then we would discontinue systemic treatment. But what we are keen on is having randomized data to support this strategy, because this is only tumor board decision made. And I'm glad that there are now new trials that are addressing the role of cytoreductive nephrectomy in patients who achieve response.
Yeah, I think I like a lot the concept of delayed cytoreductive nephrectomy, because we are offering something that with the combos, we are seeing that the response usually is much better within the metastasis than within the primary tumor. So it's nice, the idea that you can remove all the tumors. However, I think we have more open questions than real answers, because we don't have the real timing. I don't think it's really well defined what is the best moment. then I don't think we don't know exactly what is the real benefit. That's the reason we need randomized clinical trials in this concept, because we are maybe offering patients surgery and we are not really giving any more benefit for those patients with the surgery. So I like the idea, as I said, but I think we need to build in the evidence. And by the time being, we are doing delayed nephrectomy, but I think it should be very carefully selected those patients that are going to go for surgery.
I completely agree. Again, I think we still have a lot of open questions in terms of, the role of cytoreductive nephrectomy. In my practice here, sometimes I'm facing a patient that don't have, in the public health system, other option. We still have interferon to treat those patients. So in the interferon era, maybe the cytoreductive nephrectomy is still a thing that may be helpful for this patient. So it's really hard to make this decision. But I agree that when we have access to these new drugs, that we have some patients that may benefit, to deferred nephrectomy, and we are doing that, even more in our clinical practice. And I agree with Laurence that if a patient achieve a complete response, or after a surgery, we tend to stop therapy and just follow those patients.
In Japan, of course, the delayed cytoreductive nephrectomy is increasing compared with before, but we sometimes still do upfront cytoreductive nephrectomy in case only one risk intermediate only one risk factor group, and only one site, such as lung mets only. In such case, and the patient PS is good, we still do upfront cytoreductive nephrectomy.
Yeah, I think most has been said already. And from my perspective, I mean, we still follow the CARMENA study or the data. And as Masatoshi said, I mean, we also offer cytoreductive upfront nephrectomy in patients where it seems plausible. So let's say it's just one risk factor, chronic metastatic disease, low tumor burden. So in these patients, we still go ahead and do surgery first. And for all others, we do offer systemic therapy upfront and then defer the therapy in those that respond. And we do it up to 6 months. And that's just, I mean, because we think it is appropriate, but it's just in absence of data.
Thank you for that. So kind of switching gears just a little bit, what percentage of your patients actually enroll on clinical trials? And it seems like in some locations that clinical trials really actually provide an access opportunity for patients for access to medications where they otherwise would not, or access to novel therapies that are novel regimens. So, what are your thoughts about integration of clinical trials, access to trials, and actually ensuring that the clinical trials for which we enroll our patients on actually are reflective of the patient population that were to receive the medications, that it's not, it's a diverse patient population reflective of the people who would actually be treated with those meds.
Thank you, Reina. I think it's a great question. So I can answer for the entire GU group at Gustave Roussy, where we have 1 patient out of 4. So at 25% of our patients that are part of clinical trial investigating drugs. But it does highlight that 3 out of 4 are not. And I agree with you that it is a strategy, at least for us in France, where we don't have the chance that Victor was mentioning in Germany. Despite the fact that EMA can approve, we don't yet have access to drug until it is being nationally covered, so fully reimbursed. And so sometimes we have this delay where we try to have prospective real-world clinical trial where we get access to drug. Otherwise, it is more about phase 2, phase 3 registration trials that allow us to have access to treatment or to a combination.
So I would say that, first of all, that I try to offer clinical trial to every single patient, because I think clinical trials are the way. The main issue is that usually, obviously, you don't have trials for every patient. And at the end of the day, there are a lot of inclusion criteria and exclusion criteria. The clinical trials usually are quite restrictive. So I think my opinion would be like 1 every 3, 1 every 4 patients get into the clinical trials in kidney cancer. And I think one of the issues about these inclusion criteria is usually we are including a lot of patients in clinical trials, but they are quite homogeneous for the trial, but then they are losing a little bit of external validity to the real world. And that, I think that is important to consider when we are designing clinical trials. We try to be more flexible because we want to get the data from the real patients that will be seen in the clinical practice.
So I agree with Guillermo. I try to put all my patients in clinical trials, and we have for now clinical trials opened and offering patients, great options of treatment. However, this is not the reality in the whole country. I think if we think, as Brazil or Latin America, there's no culture of clinical trials. So it's a minority of patients at the end of the day that will be enrolled in clinical trials. So we need to make an effort, to make people understand the importance and how a clinical trial could be important for our patients. So I think this is an important thing to be done.
I myself, I'm working in university hospital, so I will give patient as many patients as possible to give them a good chance to use new drug. So. But probably total percent of clinical trial application patient is around 30%, 20 or 30% patient are involved in clinical trial.
In Germany, we do have a margin or cut point for a cancer center to be accomplished, which is 5% in the first initial years, and then it shall succeed up to 10% of patients for a section, let's say the GU section, who should be on clinical trials. But this is the totality of patients and will include also those that are being cured. And so therefore, those numbers are quite low. But that also kind of shifts your perspective when it comes to clinical trials, also to earlier disease, and not only for the relapsed and metastatic disease. So I think that's a different perspective that we have in our cancer centers here in Germany.
Thank you so much. So what we'll do now is actually transition to the audience Q&A. We really have enjoyed the different perspectives from our panelists. There's a question box on the bottom of the screen. Please feel free to input your questions into that box, and we'll certainly be able to ask our panelists. But Dr. Abel?
Yeah, really, really interesting and great perspectives. One question is, so for patients who maybe had a cytoreductive nephrectomy and then they're treated with whatever therapies, and they have 1 or 2 sites that are no longer responding to disease, could each of the panelists go through when they decide or when they consider either doing a metastasectomy, a thermal ablation, or stereotactic radiation, or some sort of localized radiation for local treatment of a metastatic disease?
Thank you, Jason. Great question. I think the rules we applied in the era of TKI is still valid. And in a patient who is experiencing disease progression on one metastatic site when the other sites are still responding, it is clearly the setting where we want to consider multimodal approach, either by surgery on one metastatic site or radiation therapy or ablative techniques. So this is clearly something that we discuss in tumor board so that we actually stick to the same systemic treatment, but prevent the evolution of this clone who is growing independently.
Yeah, so I would agree. I always like to remember that we have this immortal time bias and that we don't have very good level of evidence to do radiotherapy or local therapy, but we do, and the retrospective data is pretty good. So we try to do, and as probably everyone, we commend these cases in the MDT to make sure that we are getting the best for each patient. I would like to get the concept that it would be better for those patients responding and just getting the maximum response. Those patients are usually the best moment to treat with consolidation therapy. But again, we're seeing that kidney cancer usually is different. And we know that there are a lot of patients with mixed response, that they are having a very good response in many of the lesions, but there is just one or two spots which is growing and that we can control with either radiotherapy or surgery.
I believe that the most important thing when we talk about local therapies or multimodal approach is the patient selection. And I believe we need to try to select patients with good prognosis. I think in Brazil, we are using maybe a bit more local therapies because we don't have access to systemic therapy. So it's easier for us to ablate or to resect a small metastasis. So we are still using it when we don't have access to medications, even in patients that are not the best candidates for that. And this is one thing that we need to consider in this scenario.
Of course, we are doing multimodal treatment against metastatic site, and especially when medical treatment shows mixed response. So some region effective, but others not. So in case of not effective, we combine with RFA or cryo or radiation. And sometimes in Japan, it's a clinical trial, but still clinical trial. We apply sometimes carbon ion radiation. It seems to be effective, better than, more effective than normal X-ray.
Yeah, I think it's an integral part of treating patients. And when we discuss these things in our boards, I think the main driver is really what is the net benefit. I mean, because we're treating the patient and not the CT scan. So is there anything to gain by having an additional modality to treat a local progression or whatever? So I think that's the main discussion, and that kind of relates on what to offer. Let's say in metastatic disease, you have an inappropriate response in a lung lesion that is closely related to the hilus, and so proper local therapy would be pneumectomy. I mean, that would be inappropriate. And so this is how we discuss things and develop a plan for a given patient to come up with a solution that is most applicable to the total situation.
Great. So a question from the chat. When would you use a Cabo-Nivo now with the Checkmate 9ER data being presented?
Okay, so when it's available, so my short answer will be, I will be considering Cabo-Nivo in the same setting for which I consider Axi-Pembro, in patient for which I want to achieve great response. Response rates there in a symptomatic patient. And it's clear that in a patient who has a metastatic site that I consider at risk, like such as a bulky liver involvement or spinal cord compression risk, I'll be keen on using Cabo-Nivo in this patient because I want to prevent any upfront disease progression.
Yeah, I would agree. In this context, I don't know if we should really split whether Cabo, Nivo, Axi, Pembro, Axi, Avelu, any combo. I think we should explain whether tyrosine kinase inhibitor plus immunotherapy or double immune checkpoint blockade. That I think is the questions. I don't have an answer, a specific answer. I think the most simple way is yes, for those patients with high tumor burden, for those patients that you don't want progressive disease as best response, and you want response, you want to use a tyrosine kinase inhibitor as well. But I don't think it's an answer for most of the patients that we'll be seeing in the clinical practice.
Honestly, almost all my patients nowadays are receiving Cabo-Nivo because the unique clinical trial we have open in my institution is the COSMIC one. So all my patients are, probably receiving these combinations or something more. So, but I completely agree with Lohans and Guillermo. Patients probably when these medications would be available, it's not available in Brazil. However, when this medication is available, I believe that patients who benefit more will be the patients we don't want a progression at first time, patients with high volume, and I believe that those are the patients who will initiate with these kind of therapies. But I believe that it's difficult to decide, between the different options that we have, IO TKI or IO.
In Japan, Nivo-Cabo is not available now. Maybe Nivo-Cabo will be available next spring. But so far as I saw from the clinical trial data, low progressive disease rate is very attractive. So maybe if available, I would like to try to use very aggressive cases.
Yeah, I would just follow what has been said. I mean, basically, it stays in a TKI-IO place, and it's very compelling when it comes to its efficacy endpoints, PFS, hazard ratio, and I think, whether it is better than another TKI-IO combination, I think these are the questions that we have, and they cannot be answered today.
Great. Thank you. Okay, moving through. So we're going to switch it up a little bit. Oh, go ahead, Dr. Abel.
No, go ahead.
So just switching it up so we have enough time for these questions because they're definitely pouring in. So maybe two panelists going through and answering. Do you guys use company-sponsored programs to defray the costs for drugs or other patient access sort of programs? Maybe Dr. Fay and Dr. Grunwald can speak to that.
Yes, so let me start. The answer is yes, but there's no, good, industry-sponsored programs for those patients. Usually, those programs don't afford patients the whole treatment, and they afford part of the treatment, and sometimes it's a kind of a way. The patient need to find a way to get the other part of treatment. So they are not good for patients at the end of the day. But when we have, for example, the expanded access programs or compassionate use, so those are very good things that we try to offer all patients that we have.
Yeah, we don't have these programs in place. I mean, something that we really have in place is price negotiation, and so the price is really discussed based on the benefit that a given agent is providing, and so that's how we do the capping actually. So we don't have any of those company-sponsored capping possibilities.
Great, thank you. One other question coming through the chat, and maybe we can go through just all four folks, is estimate how much overall survival has improved for a typical patient in your practice over the last 10 years. And
I would say a lot.
Go with the same order, sorry.
Sorry, David. It's great. It means we're all excited about this question. So I would be tempted to say that it has more than doubled, basically.
Yeah, I would agree. And yeah, I would agree. And even though I could say that probably we are even more than doubling in many patients, but we need to wait for those patients on therapy for many years now, that they have been off treatment for many years, and we continue seeing those patients in our clinic. And the good thing is those patients are coming up.
So I still have different realities here. I have a reality where we see these gains in terms of overall survival, and we have a reality where we still see patients with metastatic RCC with median overall survival of around 12 months, and that is very frustrating.
Yeah, I agree with everyone, and yeah, almost double compared with before. And some patients shows, cure, completely cure without treating. So exciting.
Yeah, definitely. I think, it really improved a lot. And it is way more than we used to have enhanced from the cytokine era, where it was about 13 months. So now we are above 40. So this is really great. And we do see completely different courses in the clinic, like patients being free of treatment and free of disease. And it's just great. It's just great times for RCC.
Wonderful. Thank you. So I think we're going to try to squeeze in one more question. This is a question from Dr. Drake. I'm going to read the whole thing. This is seems that there's a lot of hopeful, perhaps wishful thinking of a powerful biomarker to clearly guide therapy selection, but perhaps the desire is out of proportion to the amount of work being done. He's curious as to which biomarkers are the farthest along. Is there anything at all close to being validated to the point of care where it can be used in routine clinical practice? So 1 minute, hopefully all the panelists can share their thoughts on biomarkers.
Okay, so that's a challenging question. Thank you, Chuck. I think PD-L1 is the go-to to stratify between IO and IO-TKI. And clearly this is something that we want to prospectively validate in a strategy where we would randomize patients. This one thing. The other one would be to use immunohistochemistry staining as a surrogate of the gene expression profiling signatures that have been done.
So I'm afraid I would like to say something different, but when I'm talking about personalized medicine, and this is 2020, when I'm discussing personalized medicine in kidney cancer, 2020 is equal 0. So we don't have any single biomarker that we can use today to provide or to guide any real treatment for our patients. Despite all the
I agree, but trying to add something, I still don't believe that PD-L1 expression will be the answer here. So, this is a personal view of it. I think we still need to develop, better biomarkers to select patients for therapies.
Yeah.
Of course, I agree with the importance of PD-L1, but last year our group published PD-L2. Expression of PD-L2 can be a biomarker when we select anti-PD-1 treatment or anti-PD-L1 treatment. So if tumor express PD-L2, we had better use anti-PD-1 monoclonal antibody, not PD-L1 antibody. I think it may be useful, I hope.
Yeah, the biomarker story is really tough to predict. And I would follow Laurence and say PD-L1 is a biomarker that we can use in RCC, but it's the beginning. That's where we start, and that's from where we have to develop the whole field, actually, to have a more sophisticated view on biomarkers and to break out really different subtypes of RCC cancers and offer them specific treatments. And I think that can be accomplished, and things are currently ongoing and pointing to that direction. And it's probably more the non-clear cell RCC where we do have better biomarkers available. But I think we definitely have to pursue that road. Although, when we speak about what do we have in hands today in the clinic, it is somewhat disappointing.
That's great. Thank you, Dr. McKay. Thank you for all our distinguished panel. This has really been an educational and interesting panel. We have a break now for 20 minutes. At 10:30 Eastern, we'll come back with Dr. Kalin's keynote address. Thank you.